Broadcast is now starting. All attendees are in listen-only mode.
Well, good afternoon, and welcome to today's ISCA ICAN webinar series, Having Tough Conversations About Suicide. Today we have Laura Gallo. She is a former Iowa school counselor and is now a professor at Boise State out in Idaho, and she's joining us today to talk about this very important topic. Before I hand it over to Laura, some housekeeping. We're going to keep everyone on mute to reduce background noise. If you have a question, please type it into the question bar on your webinar menu, and we will answer those questions at the end of the presentation. So Laura, thank you so much for joining us today, and I will hand it over to you.
Okay, thanks, Britt. I'm happy to be here and just to reconnect with Iowa people again, Iowa school counselors especially. I miss being there, but it's been a great experience being out here in Idaho. I'll just give you a brief background of what I've been doing. So this is my third year as a faculty at Boise State, and my research area continues to be suicide prevention. So I'm really immersed in that world pretty regularly, daily actually. And Idaho has a pretty high rate of suicide, so there's a lot of initiatives and things happening here in the state that have helped me learn so much about this area and ways that we as school counselors can really work to prevent suicide with our youth. So as Britt mentioned, please feel free to post questions, and then I'll try to answer those the best that I can at the end. I'm certainly not an expert, but I'm certainly a passionate individual on this topic. So we will go ahead and get started. All right, so this is just back to the whole purpose of what the webinar will cover today. I could literally talk about this for days, and in fact I teach a class on it which lasts for days, and so it's always a struggle for me to come up with the right amount of information that's not too overwhelming, but does help you leave this presentation with a sense of, oh, I can use that and I've learned something. So I'm doing my best to give you snippets of information, things that you can take back and use in your practice as a school counselor and or share with other staff that you work with. So the agenda for today, for our hour together, just going to talk really briefly about rates of suicide. I'm going to cover myths, importance of language, connecting with students, resources, and some question answer time. That's the goal anyway. We'll see how it goes. When I'm talking at a computer and not talking with people, I'm never really sure how long that will take, but we'll see how it goes. Uh-oh. Hang on. I don't know if I clicked out or what. Hang on. There we go. What? Why did it do that? Oh, I have the wrong PowerPoint. I am so sorry. Hang on, everybody. I pulled up the wrong one. Yep, that's the wrong one. Hang on, Britt. I'm so sorry. Just a second. Where are you, PowerPoint? Everybody gets to see my long list of PowerPoints.
I think we've all been there. It's okay.
Oh, man. I gotta diminish that so I can see. Where did it go? It doesn't help. I'm doing 2 presentations today, so I'm been busy getting both of them ready. Oh man, where'd it go? Okay, hopefully this one's it. All right, we'll try again. Okay, can you see that, Britt?
Yep, I can see it. You're good to go.
Okay, all right, let's keep going. Okay, so this is a quote by Dr. Rudd that he's an expert in suicide research, and this is a quote that he uses for a lot of his presentations, and so it's just a great reminder, right, of understanding that the people that we work with who are going through having suicidal thoughts and just in a lot of pain, right? So understanding that their pain in living is greater than their fear of dying. All right, there's the purpose. There's pretty much the same agenda. Maybe I changed it a little bit. So big picture, suicide prevention within schools, working with youth. How do we intervene and connection, resources, answer time. Okay, so here we go. I just wanted to put up a PowerPoint slide of definitions just so that everybody understands the importance of language. So I'm not going to read through each of these. I know Britt will have a copy of the webinar so that if you wanted to refer back to it, you can. But just understanding that when we're talking about suicide, there's some terms that we use to understand so that we're all on the same page, right? If somebody is attempting suicide and then for some reason that attempt is stopped, right? Is it interrupted because the person is stopped by someone else, or do they themselves stop the suicide attempt, which is an aborted attempt? And then preparatory behavior is another important aspect because it has to do with when we talk to people about suicide and we're listening for that intent, that behavior that's related to the suicide discussion, because behavior is not very different than thoughts of suicide, and it tells us a lot about their level of risk. Just a couple other things that are on the slide, and I'll talk about messaging later. But there's some terms that have gone that have become old school, right? We don't say committed suicide or committing suicide, we say they die by suicide. Or we don't use the term failed suicide attempt. We talk about them surviving a suicide attempt. So that's just some of the language that has come out of people who advocate for promoting, suicide awareness and advocating for survivors, so that we're taking some of the shame and the negative connotation with with people who have survived suicide. So just a quick slide on statistics for youth, because that's generally who the folks in this webinar are addressing and working with. So suicide, you can see, is a second leading cause of death, so pretty high rates there. There's a death every hour and 25 minutes. There's actually a more recent statistic for 2017. I don't have it on this slide, and that number has increased. So 4 out of 5 teens who attempt have been given clear warning signs. Self-injury is not necessarily related to suicide, but they can be acquiring the pattern of self-injury that can later lead to suicide. So I'm going to talk about that a little bit later also. And we do know that, of course, that children are more impulsive, teens especially, but that is not an excuse to miss warning signs. So it's difficult to find the most current data, but firearms seem to be the leading method for 15 to 19-year-olds, whereas suffocation is the predominant method for 14 and under. Overdosing with pills has also seen an increase. So, interestingly enough, I came across, I was on social media and something came across my news feed, an article from the Des Moines Register, and it had some results from the Iowa Youth Survey. So I clicked on it, and was really interesting. It talked about, as I wrote there, 1 in 10 students reported they had a plan for suicide. 1 in 20 reported they attempted. And this increased by 53% between 2012 to 2018. So that's some more specific data for you in your state about this being an issue. And it's probably not a surprise to all of you who are practicing school counselors. I think you probably have recognized more students talking about suicide. And this goes all the way down into elementary age. I don't know if I have any elementary counselors on, but I've worked with a lot of the elementary school counselors in this area, and it has become more of a trend that elementary age students are talking about suicide, using that language, oh, I just want to die, things like that. They're also exposed to social media, and there's a lot more social media influence related to violence and suicide. So some of the myths, and I'm guessing a lot of you know some of these, but or all of them, but if not, these are important and things that you can be spreading within your schools, because I think teachers still believe a lot of these myths, so, and maybe even principals. So very important items to bring back to your staff. But talking about suicide with adolescents increases suicide risk. So clearly that is not true. There's a ton of research to support that talking about it does not increase the likelihood. And in fact, talking about it with somebody who you have some concerns about, it's often a relief for them to be able to express their suicidal ideation if they have it. And if they don't, talking about it isn't planting that idea in their head. So another myth, most adolescents who attempt wish to die. Not true. Most people who attempt suicide do not wish to die. Once again, they just wish to end their pain. So their pain is so severe, they don't know any other way out. They don't have the coping skills or the tools to help them get through that. Adolescents only use the word suicide for attention. So we hear this a lot from adults who, especially with younger children, feel that they're using the word, for attention, which may be the case, right? In some situations, maybe it's become just part of their language, something that they use, but that doesn't mean that we wouldn't still give it our full attention to, or give them our attention in finding out, well, what's going on? Why are you using that word? As a sign for us to still have a discussion with them. Every adolescent who dies by suicide is depressed. That is not the case. Of course, the percentage of people who die by suicide do have some kind of diagnosable mental illness, but it's not everyone. So it's something to keep in mind too. The student doesn't have to appear depressed, so keep that in mind. And then current prevention programs are sufficient to prevent teen suicide. I wish that was the case, right? If that was the case, every school would have a very sound, reliable suicide prevention curriculum. So we need to be doing more. We need to be doing as much as possible. And then, of course, there's the issue of how difficult it is sometimes to talk about this topic within schools. Some parents are not comfortable with it. Some administrators are not comfortable with it. So there's a lot of the barriers that you will have to face in figuring out ways to make this an important part of your school, your program, your curriculum. So I totally understand that, and that was definitely something that I've run across in my research as well. So figuring out how to work through those barriers. So just a plug for SAMHSA's evidence-based programs, which no longer exists. That program has gone by the wayside, but I do have this list from the original list that came out the last time, which I think was 6 years ago. So there's a few listed there. You can research those if you want to find out more. The ones with asterisks are the ones I have used or am trained in, so I can speak more to those particular programs. And I would also recommend doing some of your own research. If you want to bring in an evidence-based program or program at all, really finding out what does the research say about it, how well has it worked, does it fit your school's needs, things like that. And you see I put more listed on pages 54 to 55. That comes from SAMHSA's toolkit for schools, high schools in particular, related to suicide prevention. I don't know if you can still find it on their website. Sometimes if you type it in, I think I have it on the last slide, the resources slide, but it's a free tool. It's pretty thick, and I actually use it as when I teach my course, because it has everything from prevention, intervention, postvention, tips and tricks, do's and don'ts. It's a great resource that I would recommend, and I think even down to the elementary school, you would find things in there that would be helpful. All right, so just in general, looking at prevention, I talked about there's different programs, and this is more of kind of a guideline of understanding what some of these different, how they describe those programs. So I don't know if many of you are familiar with upstream prevention programs, but these are programs that really look at helping schools become more strength-based or resilience-based. So you're promoting, like it says, student well-being. It's a comprehensive holistic program that promotes students using their strengths in overcoming a lot of life issues. Could be depression, could be anxiety, could be drugs, could be bullying, could be a whole lot of issues. But these upstream prevention programs really aim to not necessarily dwell on how depression or kind of all the bad things in life, but more of like how can we insert these ways to deal with the bad things in our life well before they become problems. So upstream prevention is definitely where a lot of the suicide research is heading, because they want to be addressing these issues before students have problems. But for schools who are already experiencing a lot of mental health issues in their students and just have a lot of needs, using school-wide prevention programs that train gatekeepers are really important. And when I say gatekeepers, I really mean the adults in the school. Some do train students, but then once again, you kind of get into that. There's some messaging that has to be done very carefully when you train students in gatekeeping. But gatekeeping has to do with training all of the school community in how to look for warning signs. So understanding those myths, looking for warning signs, and then helping students get access to care. So walking them down to the school counselor, or maybe the school counselor is making the referral to somebody in the community. So just putting things in place to help the school as a system prevent suicide by looking out for students. Let's see, we're going to talk about messaging here in a little bit, but I think creating a help-seeking culture is always something that I promote. So we are really trying to move away from that whole code of silence, helping students understand it's okay to let others know when you're hurting. And I think we do that a lot through teaching students how to look out for their peers, because that's really where it comes from a lot of times. It's not that you necessarily have the teen who's having some depression come to you. It's that you have their friend, right, who comes to you and is expressing concern. And then part of that culture is having adults who are welcome and opening to students coming to them with these issues. They're not afraid, they're not turning away, they're not doing anything to discourage that type of behavior. Because as you know, students, they read your body language, they read your facial expressions, they are really finding out if you're a safe adult that they can turn to. And if you do something that indicates you're not, they're very likely not going to come back to you for help. Okay, so prevention in general, right? So we have these upstream programs, training gatekeepers on a school-wide basis, and then we have intervention, which is the component where you are actually talking with a student who's suicidal, asking those questions, finding out what their reasons for living are. So that's a whole nother aspect of what we do in suicide work. And then once again, messaging is everything. We're going to talk about that again, but positive opposites. So that's what you desire them to be doing rather than what they are currently engaged in. So this is the whole idea that upstream prevention program, or that messaging where instead of talking about how depressed you are, or talking about depression, we're talking about ways to utilize your sources of strength that you have. So screenings, just a heads up, this might not be new information for some of you, but if you are considering doing screenings at your school, I have written there individual versus universal. So individual screenings would be the student who comes to your office who starts talking or has some warning signs that you think they might be suicidal. So you do a screening with them. You actually ask them about if they have thoughts of suicide, if they have started any preparatory behaviors, any planning, so that you can assess some level of risk. Universal screenings are generally like 5 to 10 questions on a survey that get handed out to everybody. So maybe it's a classroom lesson, right? That's asking, have you ever had thoughts of suicide, et cetera, et cetera. So there are some real concerns with doing universal screenings, mainly because you have to have everything you need in place before you would do that. You need to have mental health providers available so that when you collect those screening tools, you can pull in any students who are positive or who indicated yes, they have suicidal thoughts. So you need to have plenty of individuals available for that. You need to make sure you're contacting those students within the same day that you do the screenings. There's just a lot of things that you want to be really careful about if you're going to do any kind of universal screenings. So the concerns with universal screenings, like I said, just having the mental health providers available to help you with that, because as one school counselor or a few school counselors in a building, depending on how that's being done, it might be difficult to address in the same day. A lot of times you need parent and administrative support. There's going to be high costs with that. And it could create a high number of identified students, which could cause alarm. But for me, there's a lot of benefits in doing screenings. It's just, like I said, just doing that appropriately. You definitely don't want to miss a student on the day they're screened. I know personally people students who've participated in a screening and then their sheet wasn't collected and they went home and died by suicide that night. So there's just a lot of concerns with making sure that's done properly. And then of course, understanding the fluidity of suicide, right? So the day the student completes or fills out your screening might be a day they weren't suicidal, but then the next day they are. So you have to also take into account that it is one thing that's done on one day in one moment, and suicidal thoughts and feelings and behaviors don't always work that way. All right, I know I'm probably talking fast and getting through a lot of material, but I'm just hoping to give you as much as I can. So working with parents. So of course in schools we work with minors, so working with parents is a necessity. There's very, very few instances where you would not be contacting a parent, right? If their student has indicated some risk for suicide. There's all kinds of court cases. I have a whole book of them related to suicidal issues, schools didn't contact, et cetera, et cetera. So you can imagine there's a lot of risk in not letting a parent know, even if the student downplays it, has said everything they can to assure you that they're not. But if there was something that brought them in or that was raised your awareness of that, maybe it was said to a peer, you have to really consider how you handle that and possibly going a bit against their wishes of wanting you to notify their parent, right? And then I have what to do if a parent is not open to seeking help. So I'm guessing many of you have encountered this. I have, where the parent doesn't believe that the child really is having suicidal thoughts, or it's not really a risk. And I don't have any great answer to that, except you having to do what you think is best, and whether that's just checking in with the student more frequently. In some cases, it could be making a call to, I don't know, what do we call in Iowa? Now here it's CPS, but anyway, Child Protective Services, right? It's different things in different states, and I've already forgotten the language in Iowa. But anyway, so sometimes consulting with a colleague and or a principal could be appropriate if that parent's not wanting to follow through. And just recognizing, of course, that making that call to a parent could be quite upsetting for them too, right? It's really difficult for a parent to hear that their child is having suicidal thoughts. So doing what you can to support them. And of course, documentation, right? So a comprehensive approach. We're seeing more and more of this come out in the literature, that it's really not just like, oh, we're going to teach one lesson in health class to address suicide prevention, or we're going to mention it for 1 week during Mental Health Awareness Week. It really does need to be a comprehensive approach, something that's really interwoven into your school as a system. And it doesn't have to be, like I said, just negative messaging of like how bad depression is. It can also be some of these other factors, right? So promote connectedness among students, identifying students who may be at risk and getting them help, be prepared to respond if a suicide death occurs. So that post-vention piece is really important. And this came from the Suicide Prevention Resource Center. They have some great tools, all free, that you can access that could be really helpful if you are wanting to set up more of a comprehensive approach, and you can kind of evaluate what you're already doing and how that might fit and maybe what you're still missing. So the intervention piece, I work obviously with future counselors and school counselors being part of that group, about what does intervention look like. And I know you are all already trained as school counselors, so hopefully this was addressed in your graduate program, but I've also discovered that it might not have been or might not have been done very well. So just a kind of reminder of, you know, how we do intervention. So how do we know when to intervene? Well, that can look very different depending on the child, depending on the situation, but I always advise my students to really trust your gut. If you're seeing a student and they just don't quite look like themselves, you know, there's no harm in bringing them in, having a conversation. So just really asking those great open-ended questions that we've all been taught in our skills course, to just kind of find out more information. And sometimes even that connection, that reaching out, can really mean a lot to them. And even if they don't open up to you in that moment, it could be a few days down the road when they've decided you're a pretty safe person and a trusted adult that they can come talk to. So, you know, just being willing to put yourself out there and bring in a child when you have any kind of suspicions. So what does it look like? It really looks like you just asking them the question, right? Not being afraid to ask, you know, based on what you've said, it sounds like you might be having thoughts of suicide. Is that something that you've thought about, right? So just putting it out there. And I've done quite a few trainings in the last few years and talked to a lot of people, many suicide attempt survivors, and you know, about how that feels to be asked that question. And I will tell you, it's so much more uncomfortable for us to ask the question than it is for them to answer that question. Like I said, a lot of people find a lot of relief when they're able to finally tell somebody they've had suicidal thoughts. So I just really want to encourage you to ask that question, even if you're like, oh, I'm afraid it will offend them, maybe it'll turn them away. That's rarely the effect that it has. And maybe they haven't. They'll be like, no, I haven't thought about that at all. That's not something I would ever do. You know, use your judgment on, you know, are they being honest with you? Are they being genuine? And just use those counseling skills, right, to find out where they're at in that process. But I'm always encouraging my students to be brave and ask those questions, though they're really hard. In fact, when I do trainings, I have everybody go practice with somebody sitting near them. These aren't necessarily school counselors, these can be anybody in the community, and it's really hard for a lot of people. It's really uncomfortable. Usually less so for counselors, but so what do I do what if I do it wrong? So that's another concern people usually have, is like, what if I offend them, right? What if they never come back? So I just really don't want you to get caught up in doing it wrong. Just be yourself, be genuine, be authentic, and ask the question. And I, you know, that's really that's all you can do. So the most successful intervention, hardly anybody ever gets this question right when I ask, but it's actually because you think it's using this skill or using this approach, timing it just right, but it's really honestly reducing access to lethal means. So part of your suicide assessment should involve some kind of question, right, about their plan, and if their plan involves some kind of lethal mean, for example, a gun, finding out more about that, right? Do they have access to that gun? How easy is it to get access to that gun? Is it locked, but they have the key in the gun safe? So those types of things. So it's a pretty basic one, but it's also like makes the most sense. So reducing that access. All right, I'm gonna keep moving on with the intervention piece. So Thomas Joyner, wrote a book called, a couple books, but this comes out of his Why People Die by Suicide, which I found just truly fascinating. And the reason I really like his theory of suicide is because it only involves 3 things, which I think make it very easy to remember. So his interpersonal psychological theory of suicide, in his research, he has found these 3 things to be what are most prevalent with people who've died by suicide. So we have perceived burdensomeness. So if you're talking with a student and they're bringing up anything revolving around, they might not use the word burdensome, like, oh, I'm such a burden to my mom. They might, but they might not. But if they use this type of language, right, of like, oh, I feel like I'm just wasting my mom's time, or statements that really help us understand that they feel like they're a burden to their loved ones or to their friends. So thwarted belongingness. So this is their maybe they have broken up with a significant other. Maybe they are no longer part of an athletic team or a group that they've been part of for a long time. So this can also be for our LGBTQ folks who maybe they've come out and they have people turning away from them, so they're no longer feeling like they belong. It's a really important aspect of this theory and what Dr. Joyner has found in these individuals. And then the last one is fearlessness about pain, injury, and death. So they've acquired the ability for self-harm. So this kind of goes back to that idea about the cutting issue. So if people are engaging in activities that allow them to become more tolerant of their pain or or injuries, like I said, it's not about the fact that they're a cutter or they're cutting, a person who cuts, but it's really about that they're able to overcome that survival instinct that we all have. So when they talk about this a lot in the research with doctors, veterans, or people in the military, certain groups, emergency medical providers, having higher rates of suicide because they have less fear about pain, injury, and death, right? Because they're surrounded by it so often, especially within the military, who are trained to overcome their fear of pain and death, because that's part of being in war, right? So looking for these 3 things as you talk with a student, are they talking about, that burdensomeness, or are they talking about, being not part of a group that they've been part of, or their family, or something that's making them feel like they don't belong? And then have they done anything, or are they talking about anything related to building up a tolerance for pain, injury, and death? And I would include drug and alcohol use in that as well, or using those substances to cope and to lessen their pain and things like that. Okay. Moving on. So back to Dr. Rudd. Dr. Rudd and Dr. Joyner work closely together. Dr. Rudd actually coined the term warning signs way back in the day, and he gets really upset when he sees the massive lists of warning signs that are now advertised on different by different organizations, and you can get posters of them. I mean, I have some of them, but what he has found in all his research is really these are the most 5 basic warning signs that, once again, I like because they're easier to remember, right? 5 is much easier to remember than 20. So he's talked about anxiety, so not recognized, right? So maybe they don't have a diagnosis of anxiety yet, so it's untreated. So feeling anxious a lot, feeling agitated, right, which is different than anxiety. So we all know what agitation means. So you sensing a lot of agitation, hopelessness, sleep disturbance, especially in adolescents. This is probably actually one of his highest warning signs for working with adolescents, was the sleep issue. And I think most of us know teens rarely get enough sleep. They tend to, right? Their bodies are wanting to be awake later in the night and get up later in the morning, which they can't do because they go to school. So sleep issues become an issue, especially if they're on social media late into the night, playing video games, things like that. And then that perceived burdensomeness. So once again, when you're talking with students, these are 5 things that you can kind of be listening for or asking about, right? So what's your sleep like? How much sleep did you get last night? Trying to gauge some of these warning signs within your clients. And something specifically he said was not talking about stress, right? Like asking about level of stress. And that's simply because stress can be very subjective. Like I could say I'm super stressed, and to you, those same things could really not be as big of a deal. So stress is just hard to gauge. So I think that's why he focuses more on these 5 things, which are more measurable and more easy to use within that realm. All right. Let's see how many I got. Anyway, I want to make sure I have time for questions at the end. So connecting with the student and asking about suicide. So once again, this is the part where we have the student in our office. We really want to kind of find out what's going on with them. Building rapport, I think, of course, is implied, right, as counselors, but I have read enough research that I feel like it's so important that we stress this whole rapport building piece, because it can make such a huge difference, not only in them telling us about having suicidal thoughts, but also in helping them work through those suicidal thoughts, right? So helping them identify those reasons for living, continuing to come see you for support. So rapport building, though when I work with my students, they so quickly want to jump into their suicide risk assessment, right? Their interview with their client. And I'm like, wait, we need to back up and spend a little time building some rapport. And you all know those rapport building skills. I would just stress that you acknowledge that, even, when that you have huge high concerns that they're very suicidal, take the time to build that rapport. And then how do we know if the behavior is suicidal? So this would come from our questions, right? And there are lots of screening tools out there you can use. I use the Columbia Suicide Severity Rating Scale, so CSSRS. If you're looking for a more structured tool, that one is free online. They have tutorials, videos that you can watch. It is very regimented, and as far as it has all the questions listed for you. But you can also ask those questions in your own way. But that's just something you could use if you really want some assistance in working through that process. So listening for intent, once again, that tells us more about how much risk they are in with their suicide. If they're talking about having some passing thoughts here and there, that's different than, yeah, I went out yesterday to the spot where I want to, bring some pills and just go to sleep. Those are 2 very different interactions or conversations we could have with somebody. So looking for that preparatory behavior. Actually, that's the next one. Degree of preparation. What have they planned? And this tells us because this tells us a lot. So asking those questions, which really help us figure out, what they're going through, what they're feeling, what have they worked through in their mind, how much has that been an issue, How much are they thinking about that? And so once again, this can be, you know, I know it makes sense, like that, of course we would ask about suicide, but I have found that because people are so uncomfortable with this topic, sometimes they really aren't asking the questions. And so I'm just going to stress what asking about suicide really communicates to that person. First of all, it communicates that you want to know the answer, right? You're asking because you want to know, because you care. It says you don't think badly of the person. So we're taking away the shame and the stigma by asking about suicide, because we're not saying, oh, it's so taboo, we can't talk about it. So it's telling them, hey, this is an important topic. And actually having suicidal thoughts isn't that uncommon. People have thoughts of suicide. It does cross their mind. There's just a big difference in having suicidal thoughts versus preparing for suicide. It also clearly says that suicide needs to be addressed. So you're letting them know, hey, this is a really important topic and this is serious and I want to be there to help you work through this. Also, if the person is not thinking about suicide, it still shows you care. So even if they're like, never thought about that, you know, it's not a problem, et cetera, you're at least telling them that, hey, this is something that's really important to me, and so I want to be there to talk with you about it. Maybe if it comes up again, or if it comes up in the future. So just some adolescent considerations. Things that I really have learned since I moved out here, things I didn't know back when I was a school counselor. So once again, this whole idea about thinking about it, which is pretty common. I think most people can agree they've had a thought about suicide, but that's very different than working toward it. And recognizing that that can change on a, I would say daily basis, but actually an hourly basis, a minute-to-minute basis sometimes. So just acknowledging that just because we ask about suicide one day doesn't mean that we won't have to ask about it again. So this impulsiveness, it's always tricky for me to talk about because I think we all recognize with the adolescent brain that they're much more inclined to make impulsive decisions and actions. So I think that's important. But so I have here 70% of suicide attempts are made within 30 minutes of the decision, but not the contemplation. So this can last much longer. So what I'm trying to say is that it's not a reason to not ask about suicide or to not think that it's important, right? Because the contemplation piece has really been there usually a lot longer. It's just that for some of these kiddos, because they're impulsive, if they've made their decision, they actually are more likely to follow through because of that impulsiveness. So recognizing that the weapon or the means is what kills them, not the incident. So you see this promoted in the media a lot of times, like, oh, student kills themselves because of bullying. Well, we can all acknowledge how bullying played a part in that, right? Maybe it was that thwarted belongingness, things like that. But it's also, we can't use that as the one and only excuse for why they have died by suicide, right? We have lots of students who get bullied. We have lots of students who break up from relationships, and they don't all have thoughts of suicide or have suicide attempts. So we have to also acknowledge that it's a lot of different pieces, right? And that has to do with messaging. So 33% of children and adolescents kill themselves on the same day of the crisis. So that's another one of those facts or figures that I think it's important to take away from it, the fact that talking with children and adolescents is not the same as talking with adults, right? We have to consider their brain development and acknowledge that that if we have concerns, we definitely need to reach out and be connecting with them because of those developmental issues. And then working on means restriction with parents is the one thing we can do, which is trigger locks, right? Because we know that guns are the #1 means for students who die by suicide, not attempt, but die, because it's very lethal. So key to changing suicidal thinking is emotional regulation, so how to soothe yourself and how to deal with others better. So that also comes from Dr. Rudd's research. So another way of thinking about how we work with young people and where their struggles are coming from. Often it's revolved, and actually this is with adults too, it revolves around, can they calm themselves down? Can they soothe themselves? And then, which in fact oftentimes gets in the way with their relationships with others. So working on those pieces, when you want to think about more of like treatment, right, beyond working through the suicidal ideation, that's another important piece of it. All right, so I am almost through. I'm going to just kind of run through these real quick. So importance of hope. So going back to that upstream prevention, we really need to focus on hope, resilience, using the strengths they already have. Sources of Strength is a great program that's out there. It's widely used in the state of Idaho. If you're looking for a program that really focuses on that resilience piece, I would highly recommend that. But just working this into our conversations with students, and not in an ingenuine way, but just as a way to help students have hope, right? Like help them recognize that this is, this pain can end, we can work through it, things can get better, and just really trying to stress that part of it, because they might really honestly not have any hope left or see any way of getting through that. Protective factors as well kind of goes along with that. Just for us to recognize as adults, these things can really make a big difference. So making sure we spend time, if we're going to create this comprehensive program, that takes into account protective factors and helping students identify those. And back to that messaging piece. So being really careful with social media. I don't even know if I need to mention this anymore. I think most schools know. You just have to be really careful with how you talk about, a death, if there's a death by suicide. So just, there's a lot of tools out there that can give you some guidelines on how you talk about suicide. So I would just recommend that you look for those. They're also in that workbook or toolkit that I mentioned. So some other do's and don'ts. So adults need to stress that suicide is rare. We don't want to normalize the behavior. It's okay to normalize the thinking and sadness, but not the behavior. And when I say it's okay to normalize the thinking, I mean when you're talking individually with students. I would not do a classroom lesson or an assembly where you're like, yeah, thinking about suicide is pretty common. I mean, I'm not advocating for that in any way, because we don't want students feeling like, oh, this is what everybody does when they're feeling bad. They threaten, or attempt suicide. We want them to understand that suicide, it really is rare to lose students to suicide, but we want them to understand, right, that asking for help and getting help is a good way to handle when you're going through a bad time. So once again, be careful about using stats. They latch onto it because they feel like, oh, this is what everybody does. Not talking about means, sharing stories that are sad, shocking, etc. A lot of the older programs that you'll see out there, people who come in and do guest speaking, it's all about sad, shock, trauma, because they feel like that's what gets people's attention, and we have learned that that can actually be really harmful and traumatizing, and especially for those students who are already at risk with some mental health issues. So we have like contagion and things like that that can come up, so just be really careful with that. Remembering children and adolescents do have strength and resilience, and really focusing on that, letting them know there are trusted adults, no code of silence. So once again, I feel like it's really all about the peers, right? Helping peers know that they can come talk to you about their friends if they're worried, because you don't always get that student coming in on their own. No warning signs, promoting hotline. And this is a link to a great resource that talks a lot about that prevention messaging. So once again, just really trying to promote ways to work through things, that messages of hope, things like that. So once again, the thought of young people attempting and dying by suicide is scary, but we can make a difference. Honestly, reaching out, creating relationships is huge and very impactful, And then resources. So once again, that toolkit is listed there. It's the third bullet. I would simply Google preventing suicide, a toolkit for schools, high school SAMHSA, and see if you can't find a copy still online. I don't know. I think they must have some changes in things that make it a little bit harder to find sometimes. All right, Britt, I'm ready for questions.
Okay. First question. Earlier in the conversation, you were referencing page numbers, and they would like to know where specifically you were referencing.
Yeah, so that is this. This third bullet, preventing suicide, a toolkit for high schools. I use that in the class I teach, which is why it's often referenced on these slides, because I use some of these same slides, some of the content with my class. So I left them on there because if you want to get that toolkit, you'll know where to look for some of that information. But hopefully, some of my students had a hard time getting it ordered, others didn't. So hopefully you can still access it.
Okay. And you also referenced a specific screening for students. Can you repeat the name of what that screening was called?
I bet it's probably the intervention. Okay, so it's the Columbia Suicide Severity Rating Scale, CSSRS-S. I think that's the one I was mentioning. It's a risk assessment tool.
Yes, that's the one.
Yeah.
Okay. Is it appropriate to use social media to reinforce prevention programming happening at your school?
Yes, I think as long as it's got some positive messaging, yeah.
Okay. So this next question says, reducing lethal means the person agrees, but would like to know how does that tie into mindset of the right to bear arms? And what are some talking points that they can share with others when having that conversation?
Yeah, that's a great point. So if you don't know, Idaho is a very red state and they really like their guns here. So that is something I have to balance, right, with helping people understand that me suggesting that you lock your guns or put trigger locks is not saying that I don't think you have a right to own a gun. I mean, there are tons of outdoorsmen here and women who love their guns. And so for me, the messaging is, or the discussion is, you have a child or someone in your home who's vulnerable right now and they're at risk, and they've talked about in their plan that they would use a gun to end their life. And so I think most people would agree that putting something in place to keep your loved ones safe is not, infringing upon your rights. And so generally that kind of discussion goes over well. If you want more information, we have some great resources here in the state because of the fact that it's Idaho related to that. But I just kind of walk that fine line carefully, tread carefully, because I know that's an issue.
Great. Next question. When a student stresses that they're not thinking about suicide, that they don't have a plan, etc., but your gut believes them, this person still notifies parents, but sometimes I'm not sure what I'm recommending or referring them to for follow-up. What if it really was just words flying out of their mouth?
Yeah, and of course, I think many people have run into that, and I certainly have as well. And I think your gut, it does tell you a lot. So I think about, okay, what's the harm in what I'm doing? And honestly, like I said, you might have just planted a seed, right? So maybe they're not feeling suicidal right now, but it doesn't mean, right? It's fluid, right? If they are struggling in some way, doesn't mean they won't have those thoughts. And so I've just opened my door and welcomed them in, so they know it's a safe place to have that conversation. And depending on what the issues are of why they're in or why you're having that discussion, providing resources for mental health issues is always good anyway. So I don't know. Hopefully I'm answering that question. I think that's where they were going.
Well, I think part of the question is if you're still notifying the parents that the words were said, even though your gut believes that they weren't completely serious, what should the recommendation or the reference to the parents be when saying this happened, but you don't really think that there's...
Yeah, so that's a tricky one because if you talk to a lot of school administrators, they don't always want you assessing or I shouldn't say assessing, but they don't always want you telling parents like, oh, I think your child's at high risk for suicide, or I think your child's at a low risk for suicide. Like, they don't necessarily want you assigning risk because you're not necessarily somebody who does risk assessments on a daily basis. So what you might be doing instead is referring them to another mental health provider who does that pretty regularly. But beside that, I know what that person's getting at, which is how do you relate that to the parent? And I would just be really factual of like, hey, I had Bobby in today and we had, he was upset about something. So we had a discussion and it ended up coming out that, he made a comment about wanting to end his life. And so we talked through that. And I just wanted you to know that we talked through it. And I would encourage you to continue that conversation at home. And so you're not really assigning risk as if you feel like, oh, I'm really worried about Johnny in my office right now. I think he needs to go to the hospital. I don't know that he's really safe right now. That's a different scenario. In this case, based on what you've assessed with that student, it's more about it's just a factual, like, hey, Johnny was in and this is what we talked about. And I would encourage you to continue that conversation at home and checking in with him and making sure he's okay. Hopefully that helps.
Are there any other questions that anyone wants to type in at this time? And the person responded perfect to that last question, so that answer was very helpful.
Okay, great.
Any additional questions for Laura as we wrap up today?
And feel free to reach out to me if you do have like a specific situation or you need a specific resource. I have quite a few at my fingertips now that I didn't before, so I'm happy to provide that information if it's helpful.
Okay, well, I don't see any additional questions coming in. So, Laura, thank you so much for taking the time and sharing this wealth of knowledge and resources with us this afternoon. I know it was helpful. And thank everyone else. Thank you for taking the time to join us today. We did record the webinar, and it will be put up on the ICAN and the ISCA websites shortly, and we'll have a copy of Laura's PowerPoint for download as well. So thank you all for joining us, and have a great afternoon.
Thanks. Talk to y'all later.